Hello and thank you for joining us. My name is Dr. Sean Studer, and I'm an Associate Professor of Medicine at SUNY Downstate Medical School in Brooklyn, New York. I'm joined today by two esteemed colleagues, Paul Forfia from Temple University in Philadelphia, welcome, and Dr. Martha Kingman from UT Southwest in Texas. Welcome. Today's topic is going to be assessing risk in pulmonary arterial hypertension. And the specific question we're going to discuss is it time to implement specific or formal risk scoring protocols in our patient management? So let me start out with you, Paul. How important do you think it is to do formal risk scoring in your management of patients with PAH?
Well, I think it depends on how you define this term score. I think that it's absolutely crucial that we risk assess our patients with pulmonary arterial hypertension. We need to know whether the patients who are on therapy are reaching certain physiologic goals, functional goals, and so we want the presence of positive features and we want the absence of negative features. And whether those things are compiled into a score or not is perhaps a topic for another day, but it is absolutely crucial that each and every time that we see a patient, from the time we first meet them at baseline, when they're not even on therapy, to once they're on therapy, that we are assessing their functional capacity over time, their walk distance over time, their exam over time, their RV size and function over time, so that we have a sense as to whether that patient is actually moving into that low risk category on our therapies.
Good. So what I'm hearing you say is you really need a multifactorial or a multi-parametric assessment. There isn't any one thing, and we certainly don't just ask them, how are you doing? But we're putting things together into more of a composite to get a sense of where they're going from diagnosis to treatment to follow-up. That's right. So Martha, the Sixth World Symposium, as you know, in Nice, France in 2018, had a bit of discussion in the reports and follow-up about which specific risk assessment tools may be useful and how we might implement them. So I'm curious, in your practice, is there specific risk assessment tools that you utilize, and how do you implement them in the care of your patients?
Yeah, we have chosen so far to use the ERS risk assessment, which categorizes patients as low, intermediate, or high risk based on certain parameters that are assessed at diagnosis and then especially first follow-up and then thereafter. And we've been able to create what we call a smart phrase that we've integrated into the medical record. So it's actually part of the patient's note each time we see them. So when they come in and see us, we update it with any testing or their functional class or their walk test. And so we can see each time where they're falling. And the goal, of course, is to get everyone to a low risk category, as we know they do better long term.
So it sounds like you have a pretty good prompting mechanism then, right? Because one potential issue with these risk scoring methods is it may be easy, especially for trainees or people newer in the field, to not necessarily hit all of the high points. So you develop a system that really helps you capture all the things you need by having it directly programmed into your medical record.
Yes, and I think in the past it was just kind of a gestalt. We'd think about these things and we could just immediately tell where the patients were. But I think when it's in front of you and you objectively go through it, sometimes you're surprised that you think the patient's low risk, and then you really look at things and see that they're not completely low risk and maybe they need to have their therapy advanced.
Yeah, I think we've all seen some disparity between how patients might subjectively report their current functioning and how it really plays out when you go down a multi-risk scoring system such as you both described.
Right. Or you can have the RV getting bigger and the patient's still young and walking, 600 meters and saying they have very little shortness of breath. So you have to assess more than, one or two. It needs to be multi-parameter assessment.
That's great. So I think we've had a good discussion about how we might use risk assessment tools in our clinical practice and really cut to some of the important points as to why having a more comprehensive view in that gestalt can really help us in patient care. Thank you for joining us for this segment.